you all for joining our second Horizons in Neuro Oncology. I'm Lily, I'm the Neuro Oncology clinical research practitioner working alongside Dr. Williams, and we both co-facilitate this session. I'm just going to give you a couple of housewarming before then I introduce you to Mr. Bhangoo and let him give a lovely presentation for us all today. Please keep your microphones muted, but if you do have any questions throughout the presentation, you can put it into the chat box and I will monitor, but we will have an opportunity to ask questions at the end of the session. I will ask for people to fill in a Qualtrics survey at the end of the presentation and at the end of today's session so that we can get feedback and we can improve future sessions. And I've just put the survey link within the chat box now. As I said, the session will be recorded, but we will be editing the recording to make it suitable to then be shared later on. So recordings won't be made available straight after this presentation, but they will be made available at a later date. And that's all my housekeeping. So yes, and you can please turn your cameras on if you feel comfortable. But now I'm going to hand it over to Mr. Bhangoo, who's a very experienced consultant neurosurgeon from King's College Hospital, and he has a very important part in managing brain tumours, and he's going to talk to us today about maximising tumour resection while maintaining function to improve patients' quality of life. So welcome, Mr. Bhangoo, and thank you.
Thank you very much for the invitation, and thank you so much to everybody. So I'm going to now hopefully try to share my screen, so let me see how that goes.
I did forget to ask, can everyone here please myself and Mr. Bhangoo? Thumbs up or a yes would be great. I forgot to ask that important question.
So hopefully you can see my screen.
Object naming again?
Can everybody see my screen?
The screen isn't sharing just yet.
And now.
Okay, so in English, you tell me what these words are. Okay? What's this one? Yes. And this one? Yes. And this one? Yes. And this one? Yes. And this one?
Yes.
Hopefully now?
Yes, brilliant.
Wonderful, thank you. And hopefully you can see the beginnings of a presentation.
Yes, we can.
Wonderful, so thank you so much. So my name's Ranjeev Bhangoo. I'm a consultant neurosurgeon at King's College. I'm also the clinical director for neuroscience at King's College London. But my particular subspecialty interest is brain tumour surgery. And I'm going to be talking to you about some of the philosophy that we have at King's, which is largely around trying to maximise the amount of tumour that we remove whilst maintaining quality of life. So trying to achieve that balance between the best of both worlds, what we call an oncofunctional balance. I do advise industry, and so those are my consultancies, and they're relevant because we've helped to produce those technologies and bring them into the operative environment. So just a little bit about King's. We cover between 4 to 4.5 million patients, and as you can see, we're a wide variety of centres. King's Health Partners goes from Guy's and St Thomas's on the River all the way out into Kent, but the neurosurgery is done at King's College London itself, so in Denmark Hill. It's a history in neuroscience for a very long time. So many of the famous names in neurology in particular and neurosurgery have worked at King's, going all the way back to Professor Robert Todd, who's one of the most important neurologists in the history of the United Kingdom. So, oncofunctional surgery. So what are we talking about? Well, we're talking about this concept of trying to remove as much tumour as we can and at the same time preserve function. And one of the hurdles that we had with this was actually persuading neurosurgeons that the brain at the level of the white matter, at the level of the brain tissue itself had functional anatomy that could be seen, that could be monitored, that could be found. So that, as you can see on the right-hand side, one could actually remove tumour but discern and preserve important structures that subserved function, because the brain looks quite similar once you enter it in terms of its appearance to the naked eye, to the microscope. There's not much to distinguish different bits of the brain from each area, so it's difficult to distinguish function unless you understand the anatomy and unless you have techniques that allow you to meet that challenge. And so this is an early example of our work. So this is a patient who had a low-grade glioma, and actually what we can see is that this tumour, this low-grade glioma, which you can see here in the operation, was sitting directly behind the area that controlled movement. And we were able, during the surgery, to actually map out, and each of these tags refers to an area where we were able to induce movement by electrical stimulation of the brain during the surgery, and how we were able to remove the tumour, and at the end of the operation not only find the function over the surface of the brain, but find that wiring, that cabling, that pathway as it led down from the surface of the brain down into the pathways that would then go to the limbs and carry the function, allowing us to remove tumour whilst safely preserving function. And this was a very early step in terms of quite basic preservation of function by removing tumour right up against motor movement, right up against the movement of the arms and the legs. And we started to develop this and look at what percentage of patients would actually require this technique. We refer to it as brain mapping, where we map the function using a variety of intraoperative electrical techniques. And at the time of this paper being published, which was about 2020, we were finding that to allow us to resect more and more tumour more and more safely, about 40% of our patients required some degree of mapping. That figure is now closer to 60%, and hopefully by the end of the talk you'll understand why that is the case. As we got more sophisticated in our ability to map during the operation, and this is again one of the papers that we published in the scientific literature to try and disseminate this knowledge, we were able to demonstrate very subtly, as you can see here, not just how the brain function is on the surface of the brain, but how it occurs and maps as the cabling goes down to the spinal cord and down to the body, which had allowed us to remove tumour at deeper and deeper levels in the brain whilst still remaining safe and preserving function. And this is a good example of a patient where we did this. So this was a patient who had a cancer syndrome, so a syndrome called Li-Fraumeni syndrome, which predisposed them to both, well in this case, brain tumours and breast cancer. And what we elected to do here was we surgically operated on the breast cancer, or my breast surgery colleagues did. And then we operated on the brain tumour, and as you can see, this area of the brain tumour is this white area. It's quite a large area at the front of the brain. We did this operation awake so that we could remove as much tumour as possible whilst preserving the psychological function that the patient needed to remain them and to be able to remain doing their job, which in this case was a very high functioning job that really required a lot of manual dexterity as well as a lot of intellectual ability. And what we could see is at the end of the operation, we were able to remove a very large volume of tumour. You can see again, the 4 represents where we found function over the surface of the brain in terms of motor movement, moving arms and legs. The 5 represents where we found that cabling as it goes through, down. And we reached the limit of the point at which we had removed all of the tumour together with a margin of tissue around it. In other words, like a cuff of normal brain, whilst preserving brain function. And that allowed us, as you can see from these scans, to remove a very large volume of brain in a patient who was then able to go back to their work. And because we were able to remove the tumour with a margin of normal brain around it, we could actually avoid giving them radiotherapy or chemotherapy, which again improved their quality of life. We then started adapting this to mapping language, but in quite a sophisticated way, because this paper that we published basically shows not just the different areas where speech and memory and language are over the surface of the brain, but how those connections work as cabling underneath the surface of the brain. So if you start the operation, where are you going to encounter the bundles of fibers that are carrying information about understanding speech, that are then making that into a sentence in your mind, that are then making that into a sentence that you actually say physically, in other words, articulate. And we were able to find these different areas by progressively doing more and more challenging operations on patients and mapping these areas and constructing a map that we could then use to plan operations for patients in general. And here's an example of just this. So this is a tumour, and we can see the tumour here very nicely.